Welcome to Selecting the Right Anticoagulant for Your Patient. In this episode, we're going to be discussing existing VTE treatment options, algorithms, corresponding safety and efficacy profiles, along with safety and efficacy data and protocols to address treatment pathways. As we get started, I want to mention that this series is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance, and the views and opinions are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the American Heart Association. I'm Dr. Erica Shore, an associate professor and chair of the Adult and Gerontological Health Cooperative in the School of Nursing at the University of Minnesota. And joining me today is a distinguished multidisciplinary panel. Dr. Teresa Carmen.
Hi, my name is Teresa Carmen. I'm the director of vascular medicine at the Harrington Heart and Vascular Institute in Cleveland, Ohio. I also run the anticoagulation monitoring service as the medical director. My background in training is vascular medicine as well as clinical thrombosis. I'm happy to be here. Thanks for having me.
Thank you. And Dr. Sanal Bhatt.
Hi, thank you, Dr. Shore. My name is Snehal Bhatt, professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences. My clinical practice is in acute care cardiology at the Beth Israel Deaconess Medical Center in Boston. It's also a pleasure to be here.
Thank you both for joining me today for us to discuss this important topic. The first direct oral anticoagulant was approved by the FDA in 2010, and others emerged shortly after. And for most patients, DOACs are preferred over vitamin K antagonists for VTE treatment. This is a recommendation that's supported by the 2020 American Society of Hematology VTE guidelines, shown here. And this table shows the primary reason for that being that DOACs have a higher efficacy, fewer risks such as major bleeding, and lower rates of mortality when compared to vitamin K antagonists for VTE treatment. In addition to these improved outcomes, there are several distinct advantages of DOACs compared with VKAs from both a clinician and a patient perspective. So less frequent follow-up, fewer monitoring requirements, more immediate drug onset and offset effects, as well as fewer food and drug interactions. There are a few initial considerations when selecting a DOAC for VTE treatment, and we're going to get into more of the specifics of all of the things to consider. There are a few comorbidities that would affect the DOAC pharmacokinetics, including individuals with renal insufficiency, hepatic impairment, and extreme body weights, both high and low. And these conditions affect the drug clearance that can ultimately lead to adverse outcomes such as increased risk of bleeding and thrombotic events. Now that we've covered just a basic overview of DOACs, let's compare the current DOACs that are available to prescribers.
Yeah, thank you, Dr. Shore. So, as Dr. Shore mentioned, the DOACs emerged, more than 10 years ago, and the seminal studies in venous thromboembolism are also more than 10 years old. And so, all four of our DOACs are FDA approved in the United States for VTE treatment. Excuse me. But there are some differences between each of the DOACs that may be important as you think about which would be the perhaps better or easier agent to use in any given patient. And so first and foremost, when initiating anticoagulant therapy, if oral therapy is an option without any need for parenteral anticoagulant first, then that would eliminate two options, and that's purely based on the way these drugs were studied. And so, dabigatran and edoxaban, just on study design, were only used after a minimum of 5 days of parenteral therapy with either low molecular weight heparin or unfractionated heparin. And so that's the way they're labeled in the United States, whereas the studies with apixaban and rivaroxaban, respectively, those agents were allowed to be used up front as long as patients did not receive more than 48 hours of parenteral therapy. And so those two agents, as you can see, are labeled for initial primary therapy, whereas dabigatran and edoxaban are not. Additionally, if you're thinking about other patient-specific factors like renal function, can a patient swallow tablets whole? Does a patient have to take medications with or without food? These are some other nuances between the classes where if you can certainly think about, for example, if a patient has renal dysfunction, dabigatran being the most renally clear DOAC may be the least preferred option, whereas a drug like apixaban, which has the least amount of renal clearance, may be a more appropriate option or a more preferred option in that patient. For rivaroxaban, notice it is the one DOAC here for these doses that are FDA approved for VTE, where those doses do have to be taken with food. Now, it does not have to be a very large meal or a high-fat meal, but it does have to be taken with food for both of the twice-daily doses of 15 milligrams for that first 21 days and the 20 milligram dose thereafter for the next 6 months. So if a patient is working an odd schedule or has concerns about being able to take those doses with food, rivaroxaban may not be a preferred choice there. Other things to consider in hospitalized patients, if you have to think of alternative routes of administration, that can also be another way to pick DOAC. So as Dr. Shore mentioned, these are all within the guidelines. These are all recommended. They're all class 1A, but there are some nuances between each of the DOACs that for an individual patient, based on patient-specific criteria, where one agent may be a preferred agent over another.
There are multiple factors to consider when choosing the best treatment option for each individual patient. It's rather complex. We're going to try to cover some of those factors here.
So in patients who have a large iliofemoral DVT or a massive or submassive pulmonary embolism, where you may be considering an early intervention, many of these patients will put on unfractionated heparin or low molecular weight heparin early. Once the intervention is completed, DOACs are preferred in most of these patients. Certainly patients who have advanced liver disease or advanced kidney disease or end-stage kidney disease, we need to consider the right therapy in these patients. And these patients may need to be monitored very closely during their course of care. We know that some cancer patients, particularly our GI and GU cancers, or patients who have had esophageal or gastric surgeries or resections, may not be the best candidate for the DOACs. So again, we take these into consideration along with patient preference and along with understanding our bleeding risk. There are patients in whom DOACs may not be preferred, like our antiphospholipid antibody patients, and we'll talk about that a little bit later. I think we're ever recognizing more drug interactions with these agents through CYP enzyme interactions and the P-glycoprotein mechanisms. So we have to be mindful of that. We've talked about obesity, BMI, whether that's a high BMI or a low BMI, also may influence our choice of therapy. And patient preference also has to be taken into account. So there are many conversations to be had when patients initially present and in choosing a different agent or a different anticoagulant for these patients. Specifically, when we look at our different available drugs, again, most patients are going to have DOACs as first-line therapy. And that follows all of the current guidelines, whether that's ASH, ISTH, or the ACCP guidelines. However, if we have unusual sites of venous thromboembolism, whether that's a splanchnic vein, portal vein, or renal vein, we may need to think about other options. There are some patients in whom warfarin may be our preferred drug, including our patients with end-stage renal disease or very advanced chronic kidney disease. Certainly our patients with triple positive APLA and even patients with double positive APLA, I think we have to give some pause. Patients who are breastfeeding, patients with underlying or patients who are morbidly obese. And I think we all have a threshold for which we feel comfortable using our DOACs with obesity. And there are still patients in whom low molecular weight heparin need to be our preferred therapy, particularly in pregnancy. Some patients breastfeeding prefer to use low molecular weight heparin over warfarin. If patients are not able to tolerate oral intake, or they have a very high ostomy output and you're worried about pill ejection, these are patients in whom low molecular weight heparin may be preferred. If they're missing their stomach or their duodenum because of resection, those patients will not have adequate absorption of many of our other drugs. And in patients in advanced liver disease, in whom DOACs may be contraindicated and monitoring of warfarin becomes very complex, these patients may also benefit from low molecular weight heparin as initial or first-line therapy.
So we've discussed several of the benefits of DOACs and how they are generally the gold standard, but there are several groups of patients that it would be contraindicated or perhaps the efficacy is unclear at this point. Dr. Bott, would you like to make some comments about some of these conditions?
Sure. So, as Dr. Carmen first mentioned, with regards to double and triple positive antiphospholipid syndrome, here we have data that DOACs do not perform as well as warfarin with regards to recurrent venous thromboembolism. And so these are warnings on on at least two of the DOACs, rivaroxaban and apixaban. These are in the prescribing information to say, do not use rivaroxaban and apixaban, and essentially making warfarin the preferred therapy. Um, Dr. Carmen touched upon pregnancy and breastfeeding. And um, and low molecular weight heparin being the preferred agent there, that is supported by guidelines and a lot of clinical practice and a lot of clinical data. DOACs are a little different than warfarin here, and maybe it'd be worthwhile just to delineate the two. So, warfarin is teratogenic in the first trimester. Fetal warfarin syndrome is a significant concern. At this point in time, we do not have any data that DOACs are teratogenic. However, we also have no data on the safety and efficacy. And I think in clinical experience, we know that when using low molecular weight heparin, we can at least use laboratory data to guide dose adjustments over the course of pregnancy. We do not have any data to guide any dose adjustments or how we would do that in pregnant women with using the fixed dosing of DOACs. And so the lack of clinical experience and the lack of really any guidance to me make the statement here about not using DOACs in pregnancy one that I think we should take to heart. With regard to mechanical heart valves, this is also another area of data where there's minimal evidence, and the only large-scale attempted trial was with dabigatran, which did have to be stopped early because of an increase in thrombotic events in the dabigatran-treated patients. And one takeaway from that particular study that I think is worth noting is that the lowest dose that was used in that trial is the 150 milligrams twice daily dose, which is the highest FDA-approved dose for dabigatran. That was the lowest dose in that particular study. They actually studied, besides 150 milligrams twice daily, they studied 220 milligrams twice daily and 300 milligrams twice daily. All three arms had an increase in thrombotic events and valve thrombosis compared to warfarin. So while DOACs did represent a paradigm shift, and they are an option for many patients, the saying that there is no such thing as a perfect anticoagulant still exists, and these are some of the patients where DOACs should not be used. And I know we're going to talk about this a little bit later, but when thinking about the institution or health system perspective, when you think about protocols, guidances on how you want to steer clinicians towards selecting the appropriate anticoagulant, these may be some of the factors you want to build into your EHR.
There are a few additional conditions that are for consideration that, again, may be contraindicated or the evidence is unclear at this point. Dr. Carmen, do you have any specific comments you'd like to make about any of these conditions?
Sure, thank you. So while apixaban has approval for use in patients with end-stage renal disease and on dialysis, I think the primary data gives a number of us pause when using these drugs. I know, at least in our health system, we prefer to use this on more of a case-by-case basis, as opposed to having it widely stated in the guidelines. And we still prefer warfarin in many of our patients with end-stage renal disease on dialysis. Cancer-associated thrombosis, again, is a bit of a mixed bag. And I think for most patients, the DOACs are very appropriate. But we do have to give pause in our patients with cancer-associated thrombosis. When it comes to cancers, catheters, and DVT, most of the data has been done with respect to prophylaxis and preventing DVT in this population. And DOACs don't seem to necessarily prevent catheter-associated thrombosis. Cerebral vein thrombosis, we have emerging data. And I think, again, this needs to be applied on a case-by-case basis. Certainly, there are some underlying conditions, including APLA, that may limit your ability to widely apply DOACs in patients with cerebral vein thrombosis. Left ventricular thrombus is another area where the data is relatively mixed. The guidelines still suggest that maybe warfarin is our preferred therapy. But again, I think taking the full perspective of the patient into consideration is very appropriate. Similarly, with splanchnic vein thrombosis, these patients come from a myriad of different disorders, from cirrhotic disease to inflammatory disease related to either inflammatory bowel disease or pancreatitis. And I don't think any drug is one size fits all in this patient population. So a cirrhotic with very advanced liver disease may not be the right candidate, and is probably not the right candidate for a DOAC or even warfarin, and low molecular weight heparin may be preferred. In highly inflammatory states, I also find that the DOACs may not perform quite as well as if we use low molecular weight heparin or an alternative therapy in these patients. So I think each of these different disease states needs to be very much individualized with respect to the patient that you're taking care of, and not necessarily applied across, having protocols applied across a wide population per se.
We just discussed multiple conditions and diseases that certainly impact the treatment selection, and those could be revealed with a thorough and standardized H&P. And so when you think about thorough patient assessment, detailed patient education, it's time consuming for clinicians and it can be overwhelming for patients, but both are critical components in order to optimize patient outcomes. So you think about even something as simple as a type of insurance a patient has or lack thereof that could heavily influence the anticoagulant treatment option that's selected to treat VTE, as well as the ability of that patient to take the medication consistently. Poor knowledge has been associated with poor anticoagulant control, again, in part due to inconsistency in taking medications or not taking them as indicated, for example, with food. Some patients don't understand the important and concerning adverse events that can occur, particularly signs and symptoms of bleeding, and when it would be appropriate for them to seek additional help from a clinician. So we're thinking about the clinician's role. Dr. Bott had brought this up before. How do we implement these at an institutional level?
Yeah, maybe I'll just jump in and just take it since I started the conversation a little bit earlier. I think that we've talked about a lot of patient specific factors, right? And I think that the saying that the best anticoagulant for a patient is really selecting the right dose, the right anticoagulant for the right patient at the right time at the right dose. And so there's a number of factors that we've talked about that will guide you to choosing one or another. And I think the nice part is as we've also covered, there are numerous options, right? So we're not stuck with just one therapy or another. And so from a health system perspective, from an EHR perspective, trying to work with all of your clinicians that'll see these patients and touch these patients and may be involved in the initial management of these patients, thinking about, how do you build in EHRs? How do you build in protocols and guidelines? Not to be overly prescriptive, but at least just to make sure that these are on the radar screen. And so, these points are being assessed. And so you can drive patients, you can drive clinicians to selecting the right agent for the right patient.
If I can just make a comment or two, in our health system, the health system that I work in, we have an overarching document of anticoagulation guidance that covers everything from choosing prophylaxis to managing each individual drug, providing protocols to help with transition of care between anticoagulants, protocols that discuss how to reverse anticoagulants if there are complications, and who might benefit from reversal, et cetera. And even transitions between the need for anesthesia or the need for a surgery, et cetera. Guidance and guideline documents are nice, but they really cover about 90% of the situations and scenarios. And so the safety net that you get for the other 10% really comes from teaming up with the rest of the practitioners that you work with. The nurses are on the floor are important. So when doses are missed or when the patient's not compliant with taking their medication the right way, those things can be brought to attention. Pharmacy is important to help when a patient may be outside of those recommendations or those guidelines to send up red flags. There's a lot of EHR alert fatigue. So you can send up alerts on things, but unfortunately, these don't necessarily always get addressed or noticed or necessarily acted on appropriately. So you put in as many guidances as you can. At the end of the day, you still have to rely on being a team and being a system and using all of the safety nets that you have, including your consultants in hematology, your consultants in vascular medicine, your consultants, in pathology for, assistance when you need reversal agents, et cetera. So it takes a village to take care of these patients with VTE, and the guidance and the documents are one big part of that. But everybody has to play that very important role.
Thank you, Dr. Carmen, for highlighting that important role that each clinician plays in optimizing the treatment for patients with VTE. Do either one of you have any additional comments that you'd like to add before we conclude?
Yeah, I just wanted to first start by echoing Dr. Carmen's comments about the multidisciplinary team. We in our institution rely very heavily on our nursing colleagues to, adherence is certainly important and they play a big role there. But also, if we're thinking about low molecular weight heparin, is a patient comfortable with injecting? Can they inject? Do they need family help? Can we actually transition a patient home on low molecular weight heparin if they can't inject themselves? Our nursing colleagues are very, very helpful there. And then one of other things that we do at our health system with regards to medication affordability, which comes up with DOACs, hopefully not as much in the coming years, but certainly for now, and any medication where we have concerns about cost, we have a meds to beds program. And so what we do prior to discharge is we will send a test prescription just to assess for cost. So we can have those conversations in-house. And we basically just get the cost information, we share that with the patient, and then we let the patient tell us whether or not the therapy is affordable or not. And that allows us to, if we need to change therapy, we can do so in the hospital. We can keep the patient for an extra half a day or a day to make sure that there's comfort with transitioning. There's no concerns with transitioning to another anticoagulant. Or if the medication that we've chosen is affordable, then we can actually have that medication prepared, dispensed, and delivered to the bedside. So we are confident that a patient is leaving our hospital with that medication. There's reducing any potential gaps in care. So those are some other things that we have listed that I thought would be important to highlight.
Definitely great points to make, that bringing back to the slide, that continuous cycle of assessing, educating, and teaching, and then reassessing. So that example of a patient self-administering low molecular weight heparin, yes, there's a teaching component of that, and then there's a reassessment to see if there's any further teaching that's necessary so that the patient can be successful.
If I could add to that, I will say we also use the meds to beds program. And I will say too, within your EHR, if you can build educational tools, whether that's making sure that the patient gets a booklet or a handout on what is venous thromboembolism, what are the drugs that you're using. Also, educational videos. Some patients learn better by watching a video than they do by reading a book. And then the last thing we rely on with our meds to beds program is the pharmacist coming to the bedside and delivering that medication, and also having a conversation with the patient and educating. So I think educating your patient is also empowering your patient to be part of their healthcare team. And that's really important in a patient with venous thromboembolism.
Absolutely, for them to have that sense of agency. And thanks for bringing up that important point of tailoring the education style to that particular individual's, the way that they best learn. And so that can take on many forms and be very individualized. I'd like to thank Drs. Carmen and Bott for joining me today to discuss selecting the right anticoagulant for your patient. We covered existing anticoagulant treatment protocols for the usual VTE case presentation, as well as some special considerations of underlying medical conditions such as end-stage renal disease or mechanical heart valves. This highlights the importance of assessing and providing anticoagulant treatment based on each individual patient. I think we really emphasize the individualization component that is necessary in order to maximize the safety and efficacy for a patient, and ultimately to improve the outcomes for patients with venous thromboembolism. So thank you to the panel and the American Heart Association. This series is available through major podcast platforms. To claim credit, visit learn.heart.org.